Thank you, Mr. Chairman, and thank you for the invitation. To be honest, when I got this invitation, they give me this title, and I tried to avoid it, and I tried to discuss much more optimistic future aspects of radiotherapy, but they urged me to stick to the title, so I will take you through the regional irradiation for early breast cancer, and especially the clinical benefit according to risk stratification. And I will take you through the development of, let's say, two major meta-analysis on the role of regional irradiation, and then I will move, let's say, to some prospective trials, both on regional irradiation, but later on the sentinel node biopsy procedure. And finally, I will take you through some aspects, new aspects of new adjuvant chemotherapy, which has changed our practice today significantly. So let's go first to the first meta-analysis from EBCDG. This was, for many radiation oncologists, a very popular review, because what you can clearly see, if you take about risk stratification, that in patients with clinical negative, pathological negative nodes, that there is no benefit of post-mastectomy radiotherapy. However, for patients with positive nodes, you see a major benefit in reducing breast cancer mortality. Then, if you go further in detail, you could see that both on the left curve with the P1 and 3 positive nodes and for the P and 4 positive nodes, there is a benefit in terms of reduction of breast cancer mortality. So, radiation oncologists were very pleased, and they concluded that post-mastectomy radiotherapy was beneficial only in node-positive patients, but both for N13 to N and to more than 4 positive nodes. And important is, if you look at the forest plot of this meta-analysis, you could see that this was independent of adjuvant therapy. But despite this positive news, I think if you want to translate it to nowadays post-mastectomy radiotherapy, there are several limitations. And it's obviously what you have heard during this conference. There's much more use of systemic and better systemic therapy. The amount of local recurrences are much lower than in the past. There's the use of new adjuvant systemic therapy. And of course, with the sentinel node, do we need to treat axilla, yes or no? You've heard it already this week from Monica Morrow in her excellent talk. And there's another limitation that if you look at the previous trials on radiotherapy, then you would see that there's an increased cardiac toxicity, and especially the larger volume of heart that is irradiated, that the more toxicity, morbidity you will have from post-mastectomy radiotherapy. So we have a lot of challenges for us, but there's another major problem. And this slide is coming from the great lymphedema expert in the United States, Alfred Takian, and he summarized very well the major impact of lymphedema. You know very well, if you add, after axillary node dissection, radiotherapy, at least the chance on lymphedema is increased with a factor of 2. And it has a negative impact on quality of life, it has a negative impact on your body image, and it has certainly decreased the upper extremity function. So these questions we have to tackle in the trials with regional irradiation. And Tim Whelan has already referred to these trials on regional irradiation, and there are 3 trials recently published over the last years. The first one is not randomized, but a simple trial comparing left and right, comparing patients who had right-sided tumors, they irradiate internal mammary lymph nodes, and if you have left-sided, you don't treat the patient. The EOTC is a randomized trial with yes or no internal mammary lymph nodes irradiation, and then about 20 is also yes or no regional irradiation, including the axilla. And here I made a summary of the 3 trials, and you see there's a difference. First, you see here on the DBCC is only internal mammary lymph node irradiation. On the EOTC, you see the red spot. You see that also the medial supraclavicular area is irradiated, and the MA20 trial is also including the axilla. So the 3 recently published trials are a mixture, but I didn't want to go in, because of the time, to the details, just to summarize the trials results. You can see here that from these trials you could learn, for example, from the Dennis trial, that there is a benefit, but small, 2 to 3% in overall survival after regional irradiation. And clear is that in the trials there is less distant metastasis and less breast cancer mortality. And the ERC trial certainly summarized that there's no increase of mortality not related to breast cancer. So that sounds fine. The only item that in the MA20 trial, due to the addition of axillary irradiation, you see an increase from 4 to 8% by adding regional irradiation in the amount of lymphedema. So these are the trials recently published. But fortunately, I got permission from the EBCDG and to get, and also from David Dodwell, to show the slides that are presented on the San Antonio breast cancer meeting in December. And it's an amazing amount of work, and it's studying, let's say, the results of regional radiotherapy versus not in, let's say, 13,500 women with breast cancer. But you can see also that different trials were performed, 1 or 2 with axillary irradiation, 3 with only internal lymph node irradiation, and 9, that's the largest group, with including the 3 areas, internal lymph node, supraclavicular area, and the axilla, with 8,000 patients. So that's major work, and I'm glad that I can show you the results of the presentation of San Antonio. And what you can see here, if you take all trials, so the older trials before 1990 and the new trials, you can see there is a benefit in any first recurrences, and also there is a reduction of breast cancer mortality by giving regional irradiation. And so that's still an impressive result. But what is clear, and I don't show the slides, that in the older trials there was no benefit. In contrast, even, some patients are dying because of the treatment, because of heart problems, etc. So but when we move to the newer trials, you see here a difference compared with the previous analysis that I showed you from 2014, that if for regional irradiation, and that's different, therefore, from the post-mastectomy radiotherapy analysis, that you see here for the patients with pathological negative nodes, there's no benefit at all. For the pathologically N2-3 positive nodes, there's a small benefit, but it's a clear benefit and for the patient with N4 positive nodes. And it's clear that also in this subgroup of N4 positive nodes, there's an absolute improvement of overall mortality. So there's a major improvement that you can see here for nearly 9% improvement by reduction of breast cancer mortality. So if you look at the results in the forest plot analysis, you can clearly see that, let's say, if you look at the nodal states on the top, that the major effect is seen in the PN4+. Surprising is a little bit, or not surprising because of the internal mammary lymph node irradiation, that medius or central tumors are doing better with this regional irradiation. And so the combination is, let's say, medial central and the positive nodes that gives a benefit. And here you see more in detail, let's say, the target volumes. You see the major benefit on top is here if you include all the patients with internal mammary lymph node axilla and supraclavicular area. But if you look at the chemotherapy, that the effect is significant here in this area. So this suggests that the regional irradiation is independent of the use of endocrine or systemic chemotherapy. So, in conclusion from this, you can say regional lymph node irradiation is beneficial in N+ patients, and especially in the 4 and more positive nodes and the mediocentral tumors. And it's independent from adjuvant chemotherapy and endocrine therapy. So David Dotwell in EBCT concluded all the trials, there is little effect on breast cancer mortality. The overall mortality is significantly increased due to the side effects, late side effects of the radiotherapy. However, if you go to new trials after 1990, then there's a markedly effect on breast cancer mortality reductions, therefore. And the absolute mortality reduction is the greatest in the M4 positive nodes. So in principle, the new trials show clearly there is a benefit, but the conclusion is therefore different compared with the post-mastectomy radiotherapy, that the major effect is mostly seen in the M4 positive nodes. So what is left with the questions from this area? I think there are a lot of questions left. Let's say, what to do with a group of patients with mediocentral tumors with 0 to 3 positive nodes? Should we treat them, yes or no? What can we prevent toxicity, heart and lymphedema? Do we need really a treatment of the axilla after positive lymph node biopsy? And what to do after neoadjuvant chemotherapy? So let's take the first hurdle, mediocentral tumors with 0 to 3 positive nodes. I tried to, or I asked David Dotwell and EBCTC, please can you do an analysis for the subgroup, but they refused at this moment. I hope they will do it in the future. But I can tell you the way we solved that in the Netherlands Cancer Institute, because I'm so lucky with the surgeon, Emil Rutgers, that we are doing, let's say, sentinel node biopsies, both from the axilla, but also from the internal lymph nodes, and see whether they are positive or not. You can see on the slide the lymph nodes both in the axilla and internal lymph node. And if you go to the literature, and that's in line with our findings in the Netherlands Institute, there is about, let's say, maximum 1/3 of the patients will have drainage seen on the scintigraphy, but you have to inject the tracer intratumoral or peritumoral. You should not inject it in the skin. And you will find, let's say, between 8 to 27% of the patients. And it's clear that if there are positive axillary nodes, then about 40% of the patients with positive axillary nodes have also metastasis in the internal node region. And also, 10% of patients have exclusively internal lymph node metastasis. And these are published, for example, by Huang in a large series and also by Liu. And they, let's say, confirm our strategy that if you have a positive lymph node biopsy, sentinel node lymph node biopsy, then of course you have to irradiate this area. And if you have mediocentral tumors with 0 or 1 or 2 positive nodes, I think you really need more high-risk factors to irradiate after axillary lymph node dissection. So what about prevention of toxicity? I will not go into details about the effect of radiotherapy on the heart, but in principle, it's clear that the more heart that you irradiate, the more toxicity you will get. So, and the other problem with lymphedema is that the more you treat the axilla, the more lymph nodes or lymphedema you will have. For example, if you have no axillary dissection or no sentinel node, you have, of course, no lymphedema. It's increased a little bit, although not significantly, by adding axillary sampling of a sentinel node. But certainly it increased if you have axillary lymph node dissection. And, of course, if you combine axillary lymph node dissection, then you will have a major increase. And this is done by a major study based upon the literature, sort of meta-analysis about, let's say, more than 2,000 publications in the literature by Shettleman. So it sees, or it clearly makes that if you add radiotherapy to a complete axillary dissection, then the chance on lymphedema is increased significantly. So how are we trying to avoid this? We're trying to avoid this with modern radiotherapy. And here I showed you just an example that with the new methods of radiotherapy, with what we call volumetric modulated arc radiotherapy or IMRT or whatever you call it, then you can, in one session, you can irradiate the patient with sort of rotation therapy around the patient, and you have special techniques with the linear accelerator and the diaphragm of the linear accelerator that moves during the radiotherapy, and therefore you can avoid as much as possible the heart. And what you certainly should be aware of is that we have to avoid the heart by this type of treatment. And here you can see it on this slide that we combine this type of treatment with the very intensive, let's say, modulation radiotherapy with a sort of breath hold. And here you can see that in these areas we can certainly avoid the radiotherapy and to the heart. There's minimal dose to the heart. And you can see also in the axilla that we try to limit it, the amount of volume, because we use the Astro Atlas to draw the target volume, what to irradiate, and try to avoid as much as possible. And there are only, let's say, a few selective patients where we cannot get, let's say, the heart further away from the chest wall. So therefore, these patients may benefit in the future from protons, but John Modiro will talk about that. So in summary, we can conclude that in patients with positive intramedullary node, positive central node, you certainly have to irradiate this area. In 1 to 3 positive nodes, you have to be careful. The meta-analysis didn't show a major benefit. We have to wait on further analysis whether this is relevant for a subgroup of patients. But with more than 4 positive nodes, certainly the patient will benefit from regional irradiation. And most importantly, I think if you do that, you need modern radiotherapy techniques, and that will limit the chance on your side effects like heart damage and lymphedema. So the next question is, and that has been discussed already a lot, can axillary nodal irradiation replace axillary dissection? Do we need axillary treatment after positive central nodes? Unfortunately, this has been addressed in the Alliance trial, and here you can see the results. Although it's limited because it's not enough patients to get sufficient power for this analysis, but you can see there's an impressive local regional recurrence-free survival for these patients. And despite the fact that, let's say, in 27% of the patients had positive nodes in the other arm where only axillary node dissection has been taken. However, there were some comments on the trial, and we'll come back to that. And because why is this recurrence rate so low? And it's not an effect of radiotherapy to a large part of the axilla. And here you see a publication from the Milano group, and it shows that you have axillary recurrence rates after breast conserving therapy, the protective effect of the whole breast radiotherapy. And you see the upper curve is the intraoperative radiotherapy patients that have been treated, and the other group is the patients with whole breast. It is a very large group of patients, more than 4,000 patients, small tumors, negative sentinel node biopsy. And despite the fact that you see that in this large group of patients, you see that whole breast radiation lowered the risk of axillary recurrence by 2/3 as compared to IRT. So why is this not shown in the American trial, the C11 trial? Because a large group of patients, at least half of the patients, according to, let's say, a sort of inquiry, that got a lot of treatment, let's say, including a large part of the axilla, even 20% got also irradiation of the subclavicle area. And to make that clear, you can see here in the top, if you have the conventional high tankard, you can see here in the top that level 1 and 2 is included in the irradiated tangential area. While if you do to modern radiotherapy, you see that this group of patients is not included in the, let's say, modern radiotherapy where you have much smaller way of irradiation. So Jaxi et al. Concluded from that review that the Z11 trials may not be directly translated to modern conformal or partial breast irradiation. So we have to follow this analysis, and we have to look at the partial breast irradiation studies to see whether we have to take this into account in the future and be more careful with radiotherapy with the irradiation of the axilla. So, what to do with micrometastasis? Here, the IBCTS trial concluded that there is no need for radiotherapy after you have resected, let's say, microscopic disease in sentinel node biopsy. Then the Amaris trial. It's clear, and that has been shown here a lot, that with the Amaris trial there is, these slides are from Il Rutgers, where it showed there's no increase in, or let's say minimal increase in axillary recurrence, and this is certainly an important reduction of the amount of lymphedema. So if you take a conclusion, the SET11 trials, no impact. The IBCTS trial, no need for axillary treatment. The Amaris trial, excellent results with adding radiotherapy to the axilla. There's much less lymphedema, and we should, move to the neoadjuvant chemotherapy. We have learned that we got much more complete remissions. We have learned that there's some discrepancy you found in this national database that in some patients this chest wall irradiation that has a benefit, in breast irradiation not. It's unclear why this is. But also we have learned and discussed this week that with neoadjuvant chemotherapy you may have more local recurrences, but it doesn't have an impact on survival. So fortunately there are randomized trials going on, and I just want to take you to the experience in the Netherlands Cancer Institute. We worked a lot on it with Messiaen, Franke Peters and Emil Rutgers to improve the quality of the sentinel node biopsies after neoadjuvant chemotherapy. We showed the results that the high identification rate, this negative node of false negative rate is only 7%, and you have seen the results from Vitzal that even for, let's say, the TET experience, that the false negative node is only 1.4%. It's very precise. And this has led us to a major protocol for patients with lymph node metastasis, where we select patients from beforehand with PET-CT scan. You see patients with a PCR, and we propose no axillary treatment. Patients no PCR got radiotherapy, and in the patient group of more than 3 positive nodes, we will stratify them between radiotherapy or radiotherapy with axillary nodes in case of no PCR. So in conclusion, the meta-analysis has shown us, the previous one, that and through 3 positive nodes and 4+, it was beneficial for post-mastectomy radiotherapy. It was independent from adjuvant systemic treatment. The prospective trials showed that with the meta-analysis that it mainly reduces the N4 positive cases and reduction of distant metastasis and breast cancer mortality. And we learned that from the Amaris trial and SET11 trial that the excellent local regional control and survival have. And for the sentinel node biopsies, the after neoadjuvant chemotherapy, possibly we can go further and reducing the amount of radiotherapy and surgery significant, like has been suggested by Monica and Morrow this week, and we reduce the amount of toxicity and lymphedema to this patient. I will skip this. And I would like to thank for these people for sharing the data with me to prepare this talk. Thank you so much.